Hi guys, welcome to the monthly education spotlight. This month we're going to be reviewing malignant hyperthermia. Now once you've watched this video, make sure that you reach out to me and let me know. I will have you signed off on your MH competency and I will also get you your MH badge buddy. All right, what is malignant hyperthermia and why is it so important? Well, malignant hyperthermia is a severe reaction to certain medications used for anesthesia. And upon exposure to these anesthetic agents, it causes a metabolic reaction that produces a dangerously high temperature. It causes muscle contractions, so we're going to see rigid muscles or spasms. It can cause a rapid heart rate as well as some other symptoms that we're going to discuss. And without prompt and effective treatment, the complications caused by MH can be fatal. So it's very important that we recognize the signs and symptoms early and we intervene. So how often does this occur? This is a very rare condition, but it is a very fatal condition if it is not treated appropriately. Right now, the data shows that it occurs in every 1 to 5,000 to 50,000 instances. Now that's a pretty big gap. And they actually feel that more people are affected by MH than what the data shows. And that's simply because a lot of individuals have not had that exposure to these triggering agents. So we may be walking around with this predisposition, but we just haven't had the opportunity to have this reaction. So that's why there's such a big gap in this statistic. This is genetic, so it's inherited by your parents. It does affect males more than females. Sorry, guys. And those that have chronic degenerative muscular disorders do have a higher predisposition to having an MH reaction. Now, like I said, it's very fatal. 80 to 90% mortality without proper treatment. There's even a 10% mortality with proper treatment. So very, very dangerous. So what's going on at the metabolic level? This is a cellular reaction that happens upon exposure to these triggering agents. And these two triggering agents include the inhaled anesthetic gases, as well as the IV anesthetic of succinylcholine. Upon exposure to these triggering agents, we see a rapid and uncontrolled release of calcium from the skeletal muscles in the sarcoplasmic reticulum. So this calcium is exiting the cells, causing this muscular contraction, this sustained muscular contraction. Now, when our muscles work really hard, they use up a lot of energy. So our cells are depleted of that energy source, that ATP. So in order to fuel this continued muscular contraction, we're going to use up a lot of oxygen. Now, when we use up oxygen, we produce the byproduct, carbon dioxide. So we're going to see an increase in carbon dioxide production. And also, when our muscles work hard, we heat up. So we're going to see that heat production in that elevated temperature. Because of this rapid and uncontrolled release of the calcium from the cells, it degrades that cellular membrane. It breaks down and becomes very weak. And then some intracellular contents leak out into the bloodstream, specifically potassium, creatine kinase, and myoglobin. And when these intracellular components leak into the bloodstream, it can cause a lot of problems. We see hyperkalemia that causes arrhythmias. The CK and the myoglobin, as they get filtered through the kidneys, can cause rhabdomyolysis. So kind of a chain reaction that's going on here from these triggering agents. And this results in that hypermetabolic crisis. So what does your patient look like when they're experiencing this? So take a moment to think about what's going on at the cellular level and what kind of signs and symptoms you may see in your patient. Well, one of the signs is tachycardia. Our muscles are working really hard, consuming all that energy, and so our heart is having to work harder to supply blood to our muscles. We're also going to see tachypnea. Our lungs are going to have to work hard to provide that oxygen, not only to our heart, but also to our tissues. We can see hypertension from our heart working so hard initially. However, once the heart starts to wear out, we might see some hypotension as well. We're going to see those muscular spasms, especially in the masseter muscle in the jaw. We're going to see those dysrhythmias from the hyperkalemia, some PVCs, or even some runs of VTAC. The skeletal muscle rigidity, your patient's going to be really, really rigid from those sustained muscular contractions. They're going to heat up. They're going to become hyperthermic. So their temperature is gradually going to rise. We may also see some diaphoresis, some sweating, and we may see some flushing as well. And then we're going to see that myoglobinuria, and that looks like Coca-Cola. So if your patient has a Foley catheter, it's really obvious. However, if your patient doesn't have a Foley, then we may not recognize this right away. We also see an increase in the end-tidal CO2, that carbon dioxide production. So if your patient is on a ventilator and has the end-tidal CO2 monitor, we're going to see this slowly creep up. And they also experienced a mixed respiratory and metabolic acidosis. So not only are they experiencing these signs and symptoms, but their pH is starting to crash as well. Okay, so now let's talk about how to manage your patient who's experiencing an MH crisis in the acute phase. Like I said before, early identification is key. You want to recognize those signs and symptoms as soon as possible so that we can intervene. You're going to stop that triggering agent. If you're working back in the OR, you want to notify the anesthesiologist and the surgeon so that we can turn off that gas or maybe stop giving that succinylcholine. You want to hyperventilate your patient. Give them as much oxygen as possible to support this metabolic reaction. We're going to treat them with dantrolene. Dantrolene, or Ryanodex, is the only FDA-approved medication to reverse this metabolic reaction. And the dose here is 2.5 milligrams per kilogram. We have a dosing chart on our MH cart. We can repeat this dose until the symptoms subside, so until those muscular contractions subside, until we reach the maximum of 10 milligrams per kilogram. Once we reach that max dose, it's really not effective. We're also going to give some bicarb to reverse this acidotic state. We're going to initiate those cooling measures, so we're going to get a cooling blanket or ice packs to really cool your patient down. We can treat those dysrhythmias caused by the hyperkalemia. However, we do want to avoid those calcium channel blockers. We can also use dextrose and insulin to treat the hyperkalemia as well. And we're going to start initiating some supportive measures. We're going to start giving IV fluids, checking those ABGs to monitor the pH. Some thermoregulation, so we're most likely going to be dropping a Foley with a temperature probe. Getting some serum labs, and we're going to be improving our IV access. If we don't have a central line, we're probably going to be getting that as well as an A line. Now in the post-acute phase, we're going to continue our treatment. We're going to ship the patient off to ICU most likely so that we can monitor them very closely. And the recommendation is to continue dantrolene for another 24 to 48 hours. This can be done IV push every 4 to 6 hours, or the patient can be started on a continuous infusion. We're going to monitor those lab values. We're going to look at the ABGs, look at the kidney function, and we're also going to do a forced alkaline diuresis. So the patient's going to be on IV fluids with bicarb as well as some furosemide to really diurese and flush out those kidneys. Now, as I mentioned before, dantrolene or Ryanodex is the only FDA-approved treatment for malignant hyperthermia. The mechanism of action here on the intracellular level is it lessens the excitation contraction between the actin and the myosin, those fibers that cause that muscular contraction. So it blocks that action, resulting in a relaxation of those muscular contractions. So what do we need to do? We need to be proactive. We need to think about who's at risk. We need to recognize those signs and symptoms early, and we need to intervene. So we want to know who is predisposed to having an MH reaction. We know it's genetic, we know it's inherited, so we want to ask our patients if any family members have ever had any problems with anesthesia. If we know that they do have a suspected predisposition, we're going to schedule them the first case of the day where we have all of our resources and all hands on deck. We're going to make sure that we use anesthesia carts that have not been exposed to any kind of inhaled gases, and we're going to replace all those breathing circuits. If the vapor-free anesthesia cart is not available, we can also use an ICU vent that hasn't had any anesthetic agents run through it. Of course, we want to abstain from administering any of those triggering agents. And there's also the question of dantrolene prophylaxis. If we know someone is predisposed, how about giving that prophylactically? Well, they've actually found that for individuals that have a progressive muscular disorder, it can worsen that muscular weakness, and it's also extremely expensive. It's about $2,000 per vial. So that is something that has discouraged individuals from doing this prophylactically. Now, we do have some additional resources available. We've got the MH hotline. That's the 1-800 number here. And this is an excellent resource if you are experiencing an MH crisis, to dial them up, put them on speakerphone, and they can support you during this MH crisis stage. If we're off-site, we're going to call 911. So if you are in homes, if you got transferred to homes for the day, you want to call 911. We have an MH cart binder that is on the MH cart that includes Ryanodex dosing. It also has a copy of the policy, the treatment record, and role cards. So just like in a code, everyone has a specific role during an MH crisis. And it's important that we all work in concert to treat the patient. So there are specific roles associated with an MH crisis: the medication nurse, the cooling nurse, the documentation nurse, and so those are included. I also have a mock MH cart in my office, so if anyone would like to look at those different role cards or to explore the different drawers in the MH cart, you're welcome to do that. And we also have our badge buddies available. So I know this was a very quick review of malignant hyperthermia, but hopefully this was a refresher. And again, once you have completed this video, just reach out to me, let me know. We'll get you signed off, and I'll also give you your badge buddy. As always, if you have any questions, let me know, and I will see you next time.